Our next topic is chronic suppurative otitis media. We finished ASOM, acute suppurative otitis media. Now it is chronic suppurative otitis media. So from the name itself you understood, right? This is a long-standing infection in the middle ears. That is chronic suppurative otitis media. Chronic suppurative otitis media is a long-standing infection of a part or whole of the middle ear cleft characterized by ear discharge and a permanent perforation. So this is important. There will be ear discharge and a permanent perforation in the eardrum. So chronic suppurative otitis media is a long-standing infection of a part or whole of the middle ear cleft characterized by there will be ear discharge and there is a hole or perforation in the tympanic membrane. A perforation becomes permanent when its edges are covered by squamous epithelium and it does not heal spontaneously. So it will become permanent when these edges are covered with squamous epithelium, and also in that condition it won't heal spontaneously. A permanent perforation can be likened to an epithelial lined fistulous tract. So, a permanent perforation can be compared to a epithelium lined fistulous tract. You know fistula, right? There will be an external opening and an internal opening, and there will be discharge coming out from that fistula like that. Here also this perforation will act like a fistula. It will be opened permanently if it is covered with the edges are covered with squamous epithelium, means it is permanent perforation, and always the mucus will come out of the middle ear. And if it is open, what happened from the external ear, the chance of getting infection is more, and in between there will be infection, then we'll treat, then again it will subside, again there will be infection, it will be like that. So it is a long-standing infection and there will be ear discharge also. Epidemiology and incidence of CSOM is higher in developing countries because of poor socio-economic status, poor nutrition and lack of health education. So this is more in poor socio-economic people, right? So if they are not hygienic and all, there is a chance of getting it more. They have to take care of it. So in developing countries, because of the poor socioeconomic standards, poor nutrition and lack of health education, there is more chances of CSOM. It affects both sexes and all age groups. It affects both the sexes and all the age group. In India, overall prevalence rate is 46 and 16% per thousand in rural and urban population respectively. So 46 in 1000 people in rural area and 16% in 1000 people in urban population. So it can affect any age. It is also the single most important cause of hearing impairment in rural population. So hearing, it is a one of the main cause for hearing loss in rural population. Types of CSOM. This is a normal tympanic membrane. Okay, so you can see cone of light, handle of Malleus, and this part is pars densa, and the upper part is pars flaccida and or attic and antral region. Okay. Clinically, it is divided into two types, tubotympanic and eticoantral. So tubotympanic type is also known as safe type. Okay, so CSOM is two types, tubotympanic or safe type, and atic or unsafe type. So this is known as safe or benign type. It involves antero-inferior part of the middle ear cleft. So antero-inferior part, this antero-inferior part of the middle ear cleft, that is eustachian tube and mesotympanum, and is associated with central perforation. So mesotympanum is below the tympanum, this portion. So it is also known as safe type, and it usually affects the antero-inferior part, and that is the eustachian tube and mesotympanum, and is associated with a central perforation. There is no risk of serious complication. Normally, there is no risk of serious complications. And the second type is eticoantral. In eticoantral, it is known as unsafe or dangerous type, and it involves postero-superior part of the cleft. So it involves the postero-superior part. This is the etic part, right? So it will affect the postero-superior part and is associated with etic or marginal perforation. It is associated with etic or marginal perforation. So that is the unsafe type. So eticoantral. So this is the etic. So the perforation will be here or in the margins of the tympanic membrane. Then it is an unsafe type, and if it is a central perforation and in the pars tensa region and it is small, means it's a safe. The disease is often associated with a bone eroding process such as cholesteatoma, granulations, or osteitis. So, this is associated with bone erosion, destruction of bone, such as cholesteatoma. That is a condition where there is a bone destruction. It will eat the bone, and all the three ossicles will get destructed, or granulations or osteitis. That is eticoantral type. So two types, tubotympanic and eticoantral types. Risk of complication is high in this eticoantral type. That's why it is unsafe or dangerous type. So these are the types of CSOM. So these are the difference between eticoantral and tubotympanic time. Discharge. Discharge will be profuse, mucoid or odorless in tubotympanic, and in eticoantral it is scanty, purulent and foul smelling. Perforation in tubotympanic, it is a central perforation. Here it is etic on the posterior superior part or in the margins. Granulations uncommon in tubotympanic but common in eticoantral. Polyp pale in tubotympanic and red and fleshy in eticoantral, and the polyp will be seen in the posterior upper part, that is etic part only. There will be red and fleshy polyps are present. Cholesteatoma absent in tubotympanic and present in eticoantral. Complications rare in tubotympanic and it is common in eticoantral. And audiogram is the investigation we'll do to understand the degree of deafness. So audiogram, mild to moderate conductive deafness. There is a problem in the conduction of the sound. So conductive deafness. And eticoantral conductive or mixed deafness. Mixed means conductive and sensory neural deafness. Sensory neural means the internal ear, the nerve pathway is affected. So both will be there in eticoantral. So this is the difference between tubotympanic and eticoantral. So discharge we have to see perforation, granulations, polyp, cholesteatoma present or absent, complications are there or not, audiogram to check the degree of hearing loss. Next comes etiology. The disease starts in childhood and is therefore common in that age group. So it will start in the childhood, it will come after ASOM. So it will start in the childhood and therefore it is common in that age group. It is a sequelae of acute otitis media, usually following exanthematous fever and leaving behind a large central perforation. Exanthematous fever, you know, right? Fever with rashes. So it is a sequelae of acute otitis media. So after acute otitis media, if not treated properly, the perforation will be there, or that large central perforation is there, then it will leads to CSOM. It is long standing. The perforation becomes permanent and permits repeated infection from the external ear, and that case the perforation become permanent and it permits the infection from the external ear because the middle ear mucosa is open. Also, the middle ear mucosa is exposed to the environment and gets sensitized to dust, pollen and other aeroallergens causing persistent otorrhea. So, there the middle ear mucosa is exposed to the environment and it gets sensitized to dust, pollen and other aeroallergens. So the perforation is there, means from the external ear the middle mucosa is exposed to dust, pollen and aeroallergens causing persistent otorrhea. Persistent otorrhea means discharge from the ear. So there will be discharge from the ear always. Ascending infection via the eustachian tube. The first one was as a sequelae of ASOM. The second etiology is ascending infection via the eustachian tube. This we learned in ASOM also. Infection from tonsils, adenoids and infected sinus may be responsible for persistent or recurrent otorrhea. So there will be, because of the infection from tonsils or from the adenoids or from the infected sinus, the infection will spread through the middle ear mucosa via the eustachian tube and cause otorrhea. Otorrhea is nothing but discharge from ear. Ascending infection to middle ear occur more easily in the presence of infection. So ascending infection to middle ear occur in the more easily in the presence of infection. The third one is persistent mucoid otorrhea is sometimes the result of allergy to ingestions such as milk, eggs, fish, etc. So, a persistent mucoid otorrhea is sometimes the result of allergy to ingestions such as milk, eggs, fish, etc. Food allergy, right? When you learn allergic rhinitis, you might have seen the allergies, different types of allergies, right, which will cause allergic rhinitis. So in that one is food allergy. So like that, some allergens will also cause this persistent otorrhea. That is etiology. So etiology, first one is from ASOM, continuation of ASOM. Second one from the persistent infections in the upper respiratory tract. There is a chance of getting to the middle ear. And third one is from this food allergens like milk, egg, etc. So next one is pathology. The tubotympanic disease remain localized to the mucosa and that too mostly to the antero-inferior part of the middle ear cleft. So antero-inferior part, right? The antero-inferior part, that will be in that antero-inferior part. Like any other chronic infection, the processes of healing and destruction go hand in hand and either of them may take advantage over the other depending on the virulence of organisms and resistance of the patient. So like all other infection, all of this depend on the virulence of the organism and the resistance of the immunity of the patient. So the process of healing and destruction go hand in hand with the virulence of organisms and also the resistance of the patient or immunity of the patient. Thus, acute exacerbations are not uncommon. So there is a worsening of the disease is not uncommon. So, this will be in the antero-inferior part and the infections ongoing thing will depend on the virulence of organism and the resistance of the patient. Pathological changes seen in this type of CSOM are a perforation of pars tensa. This is a tubotympanic type. So, perforation of the pars tensa. Pars tensa, right, that down portion, and it is a central perforation and its size and position varies. So its size and position varies and it's a central perforation. Middle ear mucosa, it may be normal when the disease is inactive or quiescent. It is edematous and velvety when the disease is active. And that can be seen only if the perforation is big in size. So this is the tympanic membrane, right? This is the pars tensa portion and this is a perforation you can see in the tympanic membrane. And there is congestion in this tympanic membrane and this is a small safe type perforation and this can be seen in pars tensa. This is tubotympanic type. If it is here in the upper portion, then that is eticoantral type. So here we can't see the middle ear through this, right? If it is a big opening, it's a subtotal or total perforation, then we can see the middle ear. At that time, the middle ear will be edematous and velvety when it is in the active stage. Next is polyp. Polyp is a smooth mass of edematous and inflamed mucosa. You all know, right? Nose also there will be polyp. So, polyps is like a edematous. It's a mucosa, inflamed mucosa, which has protruded through a perforation and present in the external canal. So, it will be there in the middle ear, and through the perforation, it will come outside and it will lie in the external ear. So, what is the after effect of that? That will it won't allow the ear canal to heal, right? So the not ear canal, tympanic membrane heal. The hole will be permanent because of this polyp coming outside. So it's a smooth mass of edematous and inflamed mucosa which has protruded to a perforation and presence in the external canal. It is usually pale in contrast to pink, fleshy polyp seen in etico-antral type. That we see in the differences, right? References between tubotympanic and etico-antral. There you saw it is a pale pink in tubotympanic, and in etico-antral it is a fleshy, red and fleshy polyp. Ossicular chain malleus incus stapes, the bones inside the middle ear. It is usually intact and mobile, but may show some degree of necrosis, particularly of long process of incus. So normally it is intact, but it may show some degree of necrosis. So this is a polyp coming out from the middle ear and lying in the external ear canal. Like this, the polyp looks like inside the ear. Tympanosclerosis. It is hyalinization and subsequent calcification of subepithelial connective tissue. So it is nothing but the calcification of subepithelial connective tissue, and it is seen in remnants of tympanic membrane. It's seen in the tympanic membrane or under the mucosa of middle ear. It is seen as white chalky deposit, like a chalk deposit on the promontory, ossicles, joints, tendons, and oval and round window. Any of this place we can see that deposit. Tympanosclerotic masses may interfere with the mobility of these structures and cause conductive deafness. It can, if this mass will stuck in these structures, means it will interfere the mobility of these structures, right? That's why there will be conductive deafness. So the tympanosclerosis, the appearance of tympanosclerosis is like this. This is seen in the tympanic membrane. It may deposit under the mucosa also, in the promontories. Promontory means bone, ossicles, joints, tendons, and oval and round window also it can deposit. And the main disadvantage of this is it will affect the motility of these ossicles and other structures, oval and round windows and all, and that will leads to conductive deafness. It will affect the conduction of sound. Next comes fibrosis and adhesions. They are result of healing process and may further impair mobility of ossicular chain or block the eustachian tube. So fibrosis and adhesions, because of that, that is a result of healing process, right? Healing process of this tympanic membrane. So because of that, there will be the mobility is impaired. The ossicular chain mobility will impaired, and also it can cause block in the eustachian tube. So hope you understood till this. Next comes the bacteriology. Bacteria pus culture in both types of aerobic and anaerobic CSOM may show multiple organisms. Aerobic and anaerobic can be seen. Common aerobic organisms are Pseudomonas aeruginosa, Proteus, E. coli, and Staphylococcus aureus. And anaerobic bacteria are Bacteroides fragilis and anaerobic streptococcal. So these are the bacteria which will cause ASOM. So aerobic and anaerobic bacteria are involved in CSOM. Clinical features: ear discharge. It is non-offensive, mucoid or mucopurulent or constant or intermittent. So it's mucoid discharge or mucopurulent discharge. It is constantly coming or intermittent only it is coming. So this is ear discharge. The discharge appears mostly at the time of upper respiratory tract infection or on accidental entry of water into the ear. So normally the discharge appear at the time of upper respiratory tract infection, the upper respiratory tract infection, or during the accidental entry of water into the ear. Next comes hearing loss. So ear discharge, it can be mucopurulent, constant or intermittent, and it can be seen when there is upper respiratory tract infection or water enters. This is about ear discharge. Next comes hearing loss. It is a conductive type. Severity varies but rarely exceeds 50 decibel. It's a conductive type. So severity of the hearing loss won't go more than 50 decibel. Mm, and sometimes the patient reports of paradoxical effects, that is hears better in presence of discharge than when the ear is dry. So the paradoxical effect is when the ear is dry, there is no discharge, patient can't hear, and if there is a discharge, it can hear because there is a medium to conduct the sound waves. This is due to round window shielding effect produced by discharge, which helps to maintain phase differential. In a dry ear with perforation, sound wave strikes both the oval and round window simultaneously and thus cancelling each other's effect. So that is round window shielding effect. If it is dry, there is a chance of, because of in a dry ear with perforation, then the sound wave strikes both the oval and round window simultaneously and cancelling the each other's effect. That if you understood the physiology of hearing properly, you'll understand this also, round window shielding effect. In long-standing cases, cochlea may suffer damage due to absorption of toxins from the oval and round windows, and hearing loss becomes mixed type. So sensory neural will also come because when we learn the treatment, the antibiotic drops what all we are putting inside the ear is ototoxic. So that will cause that toxins will get absorbed through the oval and round window, and there will be sensory neural hearing loss. So conductive hearing loss is also already there, and because of this there will be sensory neural hearing loss also, causing a mixed type. Next kind, perforation. So first ear discharge over, hearing loss over. Next comes perforation. Always central perforation. It may lie anterior, posterior or inferior to the handle of malleus. So that will be a central perforation in past tensa, and it can be anterior, posterior, inferior to the handle of malleus. It may be small, medium or large or extending up to the annulus. Annulus is the margin, that is subtotal. So small, medium or large. Right, and then middle ear mucosa. How the middle ear mucosa appears? It is seen when the perforation is large. It can be seen only if the perforation is large. Normally it is pale pink and moist. When inflamed, it looks red, edematous and swollen. So normally it is pale pink in color, the middle ear mucosa, and when it is inflamed, it is red and edematous. Occasionally, a polyp may be seen inside the middle ear. So this is the picture showing the perforation. So this is a central perforation which is small. This is a medium-sized perforation, and this is subtotal perforation, and here it is a total perforation. Total past tensa is gone. And these are the safe type of perforations, and these two are the unsafe type, that is etic and marginal perforation. Investigation, examination under microscope is essential in every case to understand the presence of granulation or growth of squamous epithelium from the edges of perforation, and also to understand the status of ossicular chain and tympanosclerosis and adhesions. To understand that, we have to look through the microscope. An ear which appears dry may show hidden discharge under the microscope. We will, from outside there won't be any discharge, but if we examine through the microscope, we'll understand there is a discharge inside. Rarely, cholesteatoma may coexist with the central perforation and can be seen under a microscope. Whether there is a destruction of ossicles that we can see only through a microscope. Next comes audiogram. I explained already. It is used to understand the degree of hearing loss. It gives an assessment of degree of hearing loss and its time. Usually, the loss is conductive, but a sensory neural element may also be present. Cultural and sensitivity of the discharge, that is to be seen to understand, to finalize which antibiotic should be given. It helps to select proper antibiotic ear drops. And next comes mastoid x-rays or CT scan of temporal bone. It is to observe whether uh, whether it is affected the mastoid. Mastoid is usually sclerotic but may be pneumatized with clouding of air cells. So if mastoid is there, that area is clouded, and then we'll understand the mastoiditis is there, and there is no evidence of bone destruction. Presence of bone destruction is a feature of etico-antral disease. So unsafe type, there will be bone destruction. So this is the picture of audiogram. This is how the result will come after testing air condition and bone condition. And this is the X-ray of mandible. This is the mastoid air cell. Sorry, not mandible. It's a X-ray of mastoid region, temporal bone. And here comes the mastoid air cells. And in these cases, there will be clouding in CSOM. Treatment. The aim is to control the infection and eliminate ear discharge, and at a later stage to correct the hearing loss by surgical means. So the aim is control the infection, thereby arrest the ear discharge, and afterwards after doing this we have to go for hearing loss treatment, that is reconstruction surgery or surgical methods are there. Oral toilet, remove all the discharge and debris from the ear. It can be done by dry mopping with cotton buds, suction clearance under microscope, or irrigation with sterile normal saline. So using cotton bud, we can dry mop it, or we can use suction under microscope, or irrigation, washing the ear canal with normal saline. And after that, ear must be dried after irrigation. That is most important. Ear drops, antibiotic ear drops containing neomycin, polymyxin, chloromycetin, or gentamicin are used. They are combined with steroids, which can have a local anti-inflammatory effects. To use ear drops, the patient lies down with the diseased ear up. Antibiotic drops are instilled, and then intermittent pressure is applied on the tragus. This is tragus for the antibiotic solution to reach the middle ear. This should be done 3 or 4 times a day. Care should be given while instilling ear drops. It can cause maceration of the ear canal skin, or local allergy, or growth of fungus, or resistance of the organisms. Some ear drops are ototoxic. That's why we are telling, if we put that one, the round window and oval window can absorb that, and that will only leads to sensory neural hearing loss. So that is ear drops. Systemic antibiotics, internally antibiotics can be given. Precautions, that is very important. Patients are instructed to keep water out of ear during bath, swimming, and hair wash. Rubber inserts are available. We can use for swimmers and all. They used to put that rubber inserts inside the ear that can be used to avoid water entering. Hard nose blowing also can push the infection from nasopharynx to the middle ear. So that also they had to take care. Treatment of contributory causes, that is, attention should be paid to treat concomitantly infected tonsils, adenoids, maxillary, sinusitis, and nasal allergy. All this should be treated. Surgical treatment, oral polyp or granulations if present should be removed before local treatment with antibiotics, because if it is there, it won't reach the middle ear mucosa, and so it will facilitate ear toilet and permit ear drops to be used effectively. So polyps and granulation should be removed before giving antibiotics and all. Then reconstructive surgery. Once ear is dry, myringioplasty with or without ossicular reconstruction can be done to restore hearing. So once the ear is dry with the antibiotic and ear toileting and all, if it is dry, then myringioplasty. Myringioplasty is artificially putting some tympanic membrane. So if a hole is there, we have to replace that. So replacing the tympanic membrane with or without ossicular reconstruction. Sometimes in cholesteatoma and all, the bones ossicles will also distract. So there we have to remove the debris and we have to artificially implant. Closure of perforation will also check repeated infections from the external canal. After closure of perforation also, we have to periodic checkup will be there for the patients because the recurrence rate is more in CSOM. So these are the artificial prosthesis, that is TORP, total ossicular reconstructive prosthesis. This is used instead of this our normal ossicles, because there in case of destruction there won't be any ossicles, so it will affect the hearing. So reconstruction surgery means replacing with this prosthesis. So that's about the treatment of CSOM, and that's about chronic suppurative otitis media. Hope you all understood chronic suppurative otitis media. Thank you.